Hi, I'm Dr. Schlang. I'm the Chief Dental Officer of Smile America Partners. Smile America Partners and its affiliated dental practices provide in-school dental care for children in approximately 18 states. Smile America Partners and its affiliated practices treat over 500,000 children annually in school. As Chief Dental Officer, my principal roles are keeping my dentistry current, developing clinical policies and procedures, and spending over half of my time in schools providing care to the children that we serve. Along with me doing that, I work with a team, a Smile America Partners management team that is very talented and enables us to provide good quality care and get very positive reviews from the children who we provide treatment to, their parents, and the schools that these children go to. In this video, I'm going to go over the equipment we use, how we set it up in a school. I'm also going to go over the x-rays, how I diagnose, how I interact with children so that they become comfortable with me, comfortable enough to allow me to do fillings on them and provide other dental services. And also I'm going to go over the dental materials and the techniques that I use, using them to do fillings, extractions, and pulpotomies. Over 95% of their clinical work is fillings. Having said that, let me show you how we set up a dental visit in a school. This would be our x-ray station. Our x-ray station is manned usually by our team lead. She uses a Nomad x-ray, portable x-ray unit to digitally take x-rays, and she has them on her laptop computer. After she does that, she'll give the child a chart that the child will bring over to my station, and this is a treatment station. I can pull up the x-rays that the team lead took on my laptop computer. This is the dental unit that I work with. And in addition to these two stations, x-ray station, treatment station, this is where we have our dental supplies set up. We have a sterilization station. Now what we try to do is we try to have each station at least 6 feet apart from each other. And for our x-ray station, we try to, as much as possible, have behind the x-ray that we take on the child to have it face out to the outside, out the window. If not, we make sure that if there is a wall that's within 6 feet of where we take the x-ray, that on the other side of the wall there isn't anyone working or sitting. And that being said, I'm going to go back to the treatment station and tell you how I basically take care of the children and work with my dental assistant and the child. The thing that we do in school dentistry is we have a certain advantage over the dentistry that is done in a dental office. And one of the principal advantages that we have is that the child is being treated in school in an environment that they're very familiar with. The other advantage that we have is that the children come to us in small groups. And in these small groups, they usually have their friends and classmates. So they are comfortable in coming into our visit. It's not like the parent is taking the child to an unfamiliar office and the parent is waiting in the waiting room while the child goes in to have treatment done. In our situation, the child comes in with their friends and is in total view of their friends while we're treating the child. The other factor that we have going for us is that there are no expectations of us to have to provide treatment. The worst thing that can happen is if a child is uncooperative at a visit, we send the child back to their class. The child hasn't lost any time from school, and the parent hasn't been disappointed with a situation where they may have taken time off from work to take the child to the dental office to get the work done. And also, we don't have to do anything to actually do the treatment that visit so that the parent doesn't have that disappointment that the child may not want us to do. So we don't use any anxiety relieving medication. No nitrous oxide, no oral Versed, nothing. We don't give the child any verbal command to behave. We may ask the child if they'll do something for us, but we don't order a child to do anything. We don't order a child to be still and open their mouth and allow us to treat them. The child is a volunteer. And of course, we don't use any sort of physical restraint. So, in review of that situation, we don't set up an instance where we feel that we have to get the work done on any particular visit. Now, with that being said, I'm going to show you our dental equipment, and I'm going to show you how I read the x-rays and do an exam on a child. But before I do that, I want to point out that even though the child is in a comfortable environment and with their friends, what I do for each visit, and which most of our dental teams do, is they set up music in the classroom that we're set up in. So the child walks in to a friendly environment. The child walks in to a place that seems like it's a nice place to hang out with, a nice place with their friends, where music is playing. So I think the next step would be for me to introduce you to our child for this setup that we have, and I'll ask my dental assistant to bring in our child.
Carter, are you ready to have your teeth checked?
Yeah.
Great. Very exciting.
Okay, so Carter is our dental patient today. Carter, how old are you?
6.
Say that again.
6.
You're 6 years old. Okay, this is Irene. Irene has been our head dental assistant and trainer for teams that are in other states as well. And she's been with me for at least 14 years. And this is Lupe, and I think Lupe has been with us for a similar amount of time. And we're going to try to show you how we introduce ourselves to the children and how we try to make them comfortable. So we're set up now for me to examine Carter's teeth, to do an exam. But before I do that, I want to go over first the equipment that we use. And so this is the Aseptico dental unit that we use. It has an air-water syringe. It has an electric handpiece. And it has a slow-speed suction and a high-speed suction. It has bottled water and an evacuation pail there, over there. When we use the handpiece has interchangeable heads, one for a slow speed, and when we use the slow speed, that's principally for doing a prophy, and this is the high speed electric handpiece. And we use the 1-to-1 ratio on the unit for the slow speed and the 1-to-5 ratio for the high speed. Now for the high speed, it can run at a maximum of 150,000 RPMs. We use it at 2/3 speeds at 100,000 RPMs. And that gets to be important when we do our dental procedures. And it's important to use the handpiece at 2/3 speed. After the team lead takes the x-rays, they're transmitted over to my laptop. And what I do to bring up the child's x-rays is I simply either type it, after I've gone onto the computer, I either type in the child's last name, and all the children with the child's last name will come up, or I type in the child's chart number, and those x-rays, the child's chart x-rays will appear by me either typing in the last name or the child's chart number. So what I'd like to do now is to go over what kind of x-rays we take and what we're looking for. So we try to keep the number of x-rays we take to a minimum. But we want, on an initial oral exam, we want to be able to see on 1 or 2 bite wings on either side the distal of the cuspid through the last erupted permanent molar, and we want the interproximal contacts to be clear and not overlapped. We're also, in a child of early mixed dentition, we want to screen for mesiodens between the upper centrals, because if a mesiodens isn't taken out early, it can cause a poor eruption or irregular eruption of the permanent central incisors. On early mixed dentition, we also want to look for missing permanent upper laterals, another common, or let's say a 1% type of developmental anomaly that occurs. Other findings that we look for also are the deciduous, the permanent lower second deciduous incisor, lower second permanent bicuspids are often, I wouldn't say often, it's another type of a 1% occurrence. So those types of developmental anomalies are what we're looking for in early mixed dentition. In late mixed dentition, the principal anomaly that we're looking for is horizontally impacted permanent cuspids. And we want to be able to refer that situation to an orthodontist so that the permanent cuspids can be directed downwards. So we want to be able to get the bite wings I mentioned and screen at an appropriate age for the developmental anomalies that I just spoke of. When I'm looking at the bite wings and I'm looking in approximally, what I usually do is I make note of the interproximal lesions that I see. For instance, I'll have, and we note active caries, we mark it in red on the chart. So let's say I found an MO on A, a DO on B, and a DO on S, which would not be an uncommon occurrence. The children that we see in our program, they are half as likely to have seen a dentist as compared to more affluent children, and also they are likely to have 2 and 3 times as much dental disease as an affluent population. So having 3 cavities per child is pretty much the norm of what we see. It's having a child that has is carie-free and has excellent hygiene is certainly not the norm. So on the chart, as well as what we have for that I could pick up on the X-rays, and one thing I want to point out is that there's a clear view feature of our X-ray software, and it looks like an eye. And when you read X-rays, always make sure that you've pointed the cursor to it and clicked on the clear view, and you're always reading the X-rays under clear view. Another, let's call it developmental anomaly that we see quite frequently is ectopic eruption. Sometimes when the upper permanent molar is trying to come in, instead of coming in, it erodes into the upper deciduous second molar. And it looks alarming, but in over 2/3 of the cases, that self-correct. So we usually don't refer that out until we've seen the child for an extra 6-month recall and the problem hasn't resolved. So when we see ectopic eruption, don't get alarmed. It doesn't need to be referred out unless it shows up. It hasn't self-corrected on the next recall. On the child's chart, it asks for caries risk, and it's listed as low, moderate, or high. I have a pretty simple way of looking at that. A child's caries risk is low for our purposes if the child doesn't have tooth decay, has not had tooth decay, and there are no white spot lesions or any sign of tooth decay, and there is no plaque buildup. So the child's keeping their teeth clean and there are no caries. The caries risk is low. Moderate means that there are no active caries, but the plaque is built up. There's some plaque buildup. So if the child hasn't had caries, but you see if the child is not keeping their teeth perfectly clean, their risk of caries is moderate. For high risk, that means that the child has either previously had tooth decay, has current tooth decay, or has white spot lesions, noting a decalcification. We also have categories on the chart that we fill out for good, fair, and poor oral hygiene. Good means no plaque buildup. Fair and poor, well, that's relative. A lot of plaque buildup, fair hygiene. Even more plaque buildup, poor hygiene. We also ask for gum status, tooth alignment, and soft tissue. For tooth alignment, I really don't like referring children out to an orthodontist until they have their full permanent dentition. However, some children have had problems with thumb sucking or tongue thrusting, have narrow arches, and need either a palatal expander or they need a tongue crib made. And certainly those children we want to refer out to orthodontics. Minor crowding on a young child is really not a real concern, but if a child is, let's say, prognathic, or if a child has major crowding with the permanent teeth coming in, that would be another indication for early referral to orthodontics. We don't want to interrupt seeing the child for preventive care or for restorative care when we do refer out for orthodontics. So we have different categories for seeing children. 1A means we've completed the child's treatment on the first visit. 2A means we haven't completed the treatment, but we're coming back for treatment. 2B means that we don't see a possibility of handling the child in the future because of anxiety or extensive decay. So we're going to refer the child out. For orthodontic purposes, I like to keep the child as 2A, but to write down in a note to the parent that the child has crowded teeth or a narrow upper palate, and you recommend that the parent take the child to the orthodontist. Medicaid in most states only covers orthodontics for handicapping occlusion. And sometimes the cost of orthodontics is out of the reach of the parents. So naturally, this is a recommendation to the parent, and sometimes the parents can do it, and sometimes they don't have the financial means to take care of the orthodontic problems. We have an urgent care category, which is category 3. Sometimes if you have facial swelling and the child doesn't allow you to treat it, you'll want to make a special note that this child is 3B, and we will case manage, the Smile America partners will case manage that child into treatment and, within the next 24 to 48 hours. I don't see any other parts of the chart that I need to fill out right now. So after I've looked at the x-rays and I've charted the interproximal decay, I hand the chart over to my dental assistant, and then I complete the process of doing the oral exam. But before I do that, I want to go over how I relate with the child and try to get the child to be comfortable with me so that I can provide treatment to the child. So when I see a child, I try to be as friendly as I can be, and what I think a child's looking for from me is for me to be confident, calm, and basically have the same sense of humor as the child. If the child sees that I'm someone who likes to have fun and is calm, they generally feel that they can trust me. So if this was the first time that I met Carter, I would say, "Hi Carter, how old are you?"
6.
Okay, Carter, I've got a few questions for you. One is, why did the kid throw the clock out the window?
He wants to see time fly.
Excellent. And for those of you who want to be able to easily break the ice with kids, I suggest laugh out loud jokes, and they're easily ordered on Amazon. Carter, before I get to examining your teeth, I got another kind of like theoretical question for you. One is, do you like candy, cake, cookies, and ice cream?
Yes.
Do you like them a lot?
Yes.
Okay. Supposing I told you that if you cut out candies, cake, cookie, and ice cream, that you probably would never get a cavity and wouldn't have to get a filling. Would that be enough for you to say, yep, I'll cut them out. I'm not going to eat any more candy, cookies, cake, or ice cream?
No.
Is that a firm no? Okay, do you think your friends would say yes to giving up candy, cake, cookies, and ice cream?
No.
Okay, that's kind of what I thought. So Carter, I'm going to examine your teeth soon, but before I do, I want to show you some of my helpers that I use when I do examine teeth. So on any given day, this can be either Mr. or Mrs. Thirsty. Try it out. It's like a reverse straw, and that helps get the saliva out. And I have this, and his name is Mr. Wind. Now, do you know why his name is Mr. Wind?
Why?
Because he's very windy. And it makes it feel like there's a hurricane going on inside the room. Got it?
Yeah.
What's his name?
Hurricane.
No, Mr. Wind. No, it's not hurricane, it's not windy. What's the name? Mr. Wind.
But you
Okay.
could use those other choices, right?
Mrs. Thirsty, Mr. Wind, or Mrs. Wind, and Mr. Thirsty. Okay? All right. So anyway, I find that Mr. Wind is very helpful in kidding around with a child. It makes a child more comfortable with me. And before I examine a child's teeth or I work on a child and do procedures, I want to get a smile. I want them to be able to smile. Now, Carter, which of these phrases that I say do you like the most? Open up and let me look at your teeth. Or, no, there's more choices here. Or, open up and let me look at your teeth, okay. Or, open up and would you let me look at your teeth? Please do it for me. Which one sounds the best to you?
The first.
The first one. Open up and let me look at your teeth. So when I work with different assistants, and I work in multiple states, a lot of the assistants I work with, they say things that are pretty innocent, but sometimes when a child is right on the borderline of being anxious, it could be a problem. So I prefer that the assistants don't say, okay. And what I mean by that, I prefer that they say, Dr. Schlang's going to examine your teeth, open up. I prefer, or Dr. Schlang's going to count your teeth. I don't really like them to say, Dr. Schlang's going to count your teeth, okay? Or I'm going to polish your teeth, okay? Or I'm going to put fluoride on your teeth, okay? And the reason that I personally don't like that is it gives the idea to the child, or it may give the idea to the child, that it might not be okay. So when I work with dental assistants, I ask them if they could try to hold down the okay. And sometimes they'll say something to a child like, could you put your hands down? Well, can you do it for me? It's not a personal thing that they should be doing for one particular person, because I'm thinking like, wow, maybe would he do it for me or only for you? So anyway, these are perhaps nitpicky points, but I want to point out to you that sometimes with an anxious child, it can spell the difference between the child cooperating and not cooperating. When I have a very anxious child, I try to do all the talking because I know that each word is important. So before I start a visit, usually I go over these things with my dental assistant, and I also point out to my dental assistant that if I'm going to give local anesthesia, I'm not going to have a conversation about it. I'll give a cue, like I'll say lido-septicane, or I'll say, no, take that back. I'll say topical septicane, and that means give me the topical, set up a syringe with a short 30-gauge needle, and because I'm going to administer local anesthesia. So let me go to doing an exam on Carter, and I'll need a mirror. Thank you. Thank you, Lupe. Now, when I do an exam, I don't wear my reading glasses. I wear my loupes. And my loupes are the most important thing that I have to do an exam, because when I do an exam, I'm using magnification, good lighting, and dry teeth. Without the magnification, I really can't do a good exam. Without the magnification, I really can't do dentistry the way that I want to. In the first 20 years of my practice career, I didn't wear loupes. I started wearing loupes about 20 years ago. A dentist who's in their 20s and 30s probably can get away without wearing loupes, because one of the main reasons for wearing loupes is for the dentist to develop good posture. However, once you're in your 40s, your close vision gets poorer and magnification becomes essential. For approximately the last 20 years, dental schools have required their dental students to wear loupes. So if dental students have been required to wear loupes for the past 20 years, there are very few dentists who are under 45 who are educated without loupes. Anyway, I wear 4-power loupes with a pretty wide field. It lets me see 3 or 4 teeth in my field of vision. And in order to do the dentistry the way that we need to do it in-school dentistry, loupes are essential. And my loupes have a light that is part of the loupe setup for those of you who don't have lights that are part of your loop setup, we have headbands that contain good lighting. So to do an exam, I put my loops on, or to do anything, to do any dental procedure, I put my loops on. And I want to make sure my light is focused. And I can dry the teeth with air. Now, most times, I'm not going to do my exam with an explorer. Explorers are no longer used to probe teeth for sticks. That damages teeth. What explorers are used now is to debride teeth. If you have debris in the grooves, you use an explorer so you could clearly see the grooves, pits, and fissures of the teeth. Anyway, I gave my pitch on the loops. I can't emphasize enough how important loops and good lighting are to doing good dentistry. So let me do my exam. Drying Carter's teeth. I already noted the pretend interproximal lesions, and when I was looking at the x-rays and marked them in red. So now I'll call out the exam. Carter has has 3 A, B, C, D, E, F, G, H, I, J, 14, 19, KLM, N, 24, 25, R, QR, ST, and 30. He has no caries. And his hygiene is good. However, let's say I discovered that Carter had plaque on his teeth. Well, let me back up a little bit. I'm going to ask you some questions, Carter. Okay? And this is the answer. Okay? So how many times a day should you brush your teeth?
2.
For approximately how many minutes?
2.
And how many times should you have a checkup with the dentist per year?
2.
Perfect. You get 100% on your quiz. Okay. Do you know how you could tell, or let me show you how you could tell if you're brushing your teeth good enough. I'm going to take your fingernail. I'm going to scratch your tooth right on the neck of your tooth. And I'm going to scratch this tooth on the neck. And what do you see on your fingernail?
White.
Okay, you see white stuff on your fingernail. The white stuff is plaque. Plaque, even though it looks innocent and it's just a white little film, that's what causes cavities. Because there are little bugs in the white stuff. They eat sugar, they spit out acid. The acid puts a hole in your tooth, and that's called a cavity. You want to avoid cavities. What you want to do is keep the white stuff off your teeth. So if during the day you scratch your tooth and you get white stuff under your fingernail, that tells you either at night when you brush your teeth or in the morning or both, you need to brush better. Okay? Now for Carter is 6 years old. He's getting to the age where he can brush his teeth on his own. But what I recommend to parents is that until a child is 7 years old, that they brush their child's teeth for them. As far as this test, which I call the scratch test, I think it's probably the most effective thing that I have found to enable children to determine whether they're brushing their teeth enough, and also to explain to them how a cavity happens. Brushing their teeth twice a day for approximately 2 minutes each time tells them what to do, but it doesn't really tell them exactly why. If they know that the plaque that they can scratch off their teeth is the cause of a cavity, if they know that the plaque produces an acid and the acid can put a hole in their teeth, decalcify, demineralize their tooth, and they know how to check for that during the day, that gives them an excellent tool to understand that if they keep their teeth free from the plaque, they're very unlikely to get a cavity. Some of you may be thinking, well, that doesn't sound very hygienic for a child to be doing that during the day. Having seen the number of children that I see, or have seen over the past 14 years as the dental director, I can tell you at least half of the kids I see, they bite their nails. And that's not so hygienic either. So from my perspective, scratching the child scratching their tooth during the day to see if they've been brushing good enough is acceptable. It may not be for you, but it worked. I've been concentrating on trying to change the child's brushing behavior and making it so that I can come to visits and see their teeth plaque free because they've been brushing enough by promoting the scratch technique. Don't know yet if it's how successful it is, but it seems like a good idea for me. So let me continue with my exam on Carter. So I think I gave you all the erupted teeth, and that there's no existing fillings in his mouth, and he doesn't have decay. But he needs sealants on 3, 19, and 30. Now 14's erupted, but there's an operculum over the occlusal surface, so 14 will seal at another time. So Carter, you need sealants, and I want to show you what I use to apply the sealants. This is what we use to apply sealant. Now, some kids, when I show them this, they think, is that pointy? Is that a shot? Was that any thought that you might have?
No.
Good. So let's say you were anxious and you were afraid of what this was, and it certainly doesn't look scary to me, but for 4 and 5-year-olds, and even sometimes older kids, they think that this is anesthesia. So what I do for them, if they'll let me, I'll put the sealant material on their fingernails. If they don't let me, I'll put the sealant material on my own fingernail. So I'm going to put sealant material on Carter's fingernail, and what I do is I put a dot, but I need another tip. Nope, that's not going to work either. Light blue tip. To put on sealant material, we use a 25 gauge tip. Also for our etch, we use a 25 gauge tip. This is our etch. And 25 gauge tip is light blue. For everything else, we use a 22 gauge tip, which are black. This is the etch I prefer. It's called Ultra Etch by Ultradent. It's very creamy. However, like most etch, does not have a good taste. This is the sealant material. It's not a shot. And for kids who are afraid of the syringe, what I do is I put a drop on each fingernail. Then I ask for that to be set up. And Carter, touch those. And how do they feel?
It feels weird.
Does it feel hard?
Kind of.
And it came out liquidy, and now it's hard. So that's what a sealant is. Also, that's kind of what a filling is. Okay. So now that I've shown Carter that a flowable syringe is not an injection, it's nothing to be afraid of, it's not a needle, I'm going to ask Irene if she'll give me the treatment plan that I gave her for Carter. So this is a Post-it, and when I do treatment, I like everything that I'm going to be doing on the child to be put on the Post-it. And then after I'm done with treatment, I know what I've done by looking at the Post-it, and I'll either write up the chart personally using the Post-it to fill in the fillings that I did, or I'll have my assistant write up the chart, and I'll review the chart looking at the Post-it. So for me, it's very important that all of you, after you do an exam, that the assistant write up the treatment that you may be performing that day on a Post-it. Now, depending whether the child seems calm and I seem to have a good rapport with the child, is usually the determinant of whether I'll do the child's restorative care at the same time that I do the exam. If I can, I want to do that because the child, I know if I spent the time getting the child comfortable with me, the child will give me approximately a half hour of time if I can give the child a comfortable experience while I'm getting the dentistry done. I use a technique with the electric handpiece to be able to do approximately 80% of the fillings that I do without local anesthetic and without hurting the child. The other 20% of the time, I'm using local anesthetic. So in order to evaluate whether I'm going to use local or not use local, it's generally the procedure that I'm going to be doing and how old the child is. If a child is over 8, a child is usually very acceptable to local anesthetic. If a child's under 8, the needle is a big deal, and they want to avoid needles as much as possible. So for Carter, let's say I was going to use local anesthetic on Carter. What I would say is topical and septo, please. And that's a cue to my dental assistant. I think it'll just blow up. That's a cue to my dental assistant to give me topical anesthetic and to set up a syringe with Septicane It says articaine, and I use 30 gauge short needles for giving an anesthetic. So considering that I have a good rapport with Carter, after I've received my post-it with the treatment plan, I'll simply say to Carter, hey Carter, I've got some sugar bugs to chase in your mouth, so what I need for you to do is tilt your head back, close your eyes, and no peeking. And I will put the topical on Carter's mucosa and gingiva. And I'll probably do that for at least a minute. And then for infiltration, I usually use, or I almost always use, articaine. And the reason why, for infiltration anesthetic, articaine penetrates bone better than lidocaine does. For a mandibular block, I'll use lidocaine for the mandibular block because the mandibular block isn't dependent on the anesthetic's ability to penetrate bone. So if I'm, let's say, going to try to anesthetize the deciduous molars, what I do is I pull the upper mucosa tight, and the way that I grab my syringe is underneath the headrest, and we need to put that back on, and have my dental assistant pull off the needle cap. And I pull the mucosa tight, and I keep chanting, no peeking, no peeking, no peeking. And then I'll penetrate the mucosa very slightly, and then push with my thumb very slightly. And before I give any other kind of push, I'll count in my head 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then I'll push. So I do that for any infiltration that I do. And usually if I'm going to infiltrate for getting articaine anesthesia for the lower deciduous molars, I will pull the mucosa taut and do the same thing. Now, what I find with the children is that they are less disturbed by the upper one than they are in the lower. And I find that once I've given the upper injection, that, let me hang on to this for just one moment. Once I give the upper injection, if they feel the lower a little bit, they give me a pass because they know that the upper went so well. I want to show how I give my mandibular blocks. And the way I do it, on the left side, open Carter, I feel the ascending ramus with my thumb, and then I go approximately a ½ inch distal to my thumb, come over the opposing mesial of the first molar, or approximately, penetrate, push, count, wait, and try to get to the bone, and then I can push, count, wait, and know that I'm not injecting into muscle. On the right side, open wide Carter, I put my finger, my index finger, on the ascending ramus, and I come in from the opposite side, and I come in, I have the needle go in approximately a ½ inch distal to where my index finger is palpating the ascending ramus. As far as what my dental assistants are doing at that time, I encourage my dental assistants to be ready, but not to put their arm over to prevent the child from having their hands go up. And the reason why I do that is because sometimes a child is peeking. And if the child, even though I'm chanting, no peeking, no peeking, no peeking, if the child's peeking, sometimes the hand going over the chest makes them jump because they're going, uh-oh, something bad's going to happen. So that's the way I give local anesthetic. Now, I spoke about 80% of the fillings that I do, I'm not using local anesthetic. And I'm not going to need Carter for this part, so you're free to hop up and go use your iPad or whatever.
Can I go eat candy?
Wait a minute, wait, before you, I like that question. Could I go and eat candy? I forgot about certain props we had. So let's see what we have in the way of props. Now, we have M&Ms, we have Cracker Jacks, and for those of you who are wondering how we got Carter to come today, you know, it was like, do you want to go play? Do you want to come do this video with me? We have Red Vines. And, wait, you're almost done. You're working now. Okay. Starburst. Out of these four, which is your favorite?
Red Vines.
Red Vines for you. How about Starburst? You like those?
Yes.
Take it. How about Cracker Jacks?
Not really.
M&Ms?
Not really.
Okay. Well, you got two you like. My point with that is kids really like candy, and you could, if what you're bribing them with the candy for is if it's reasonable, they'll go for it. Even come and do a video. Okay, so where we left off, I pretended to give Carter some local anesthetic. But let's say I was going to work on Carter without giving local anesthetic and doing his fillings. Well, I have to be able to let him know what to expect. So usually what I'll say is, you have some sugar bugs, and I'm going to go chase those sugar bugs, so I need you to open up, and if you feel anything, it'll feel a little bit like cold water. But if you feel anything more like cold water, what I want you to do is to raise your left hand, and that means stop to me. If you keep your left hand down, that means go to me. Now, usually I'll say that, but a lot of times I won't bother with the left hand up for stop and the left hand down for go. If I feel like the child really needs to be able to feel that they are in control of the situation, then I'll do the left hand up means stop to me, the left hand down means go. And while I'm working, the left hand up doesn't always mean stop to me, it means go do your drilling somewhere, some other spot, not where you are right now. I try to just be friendly and kid around with the child and just say, I'm a tooth bug chaser. Now, for those of you who are not familiar with doing procedures without using local anesthetic, I can tell you that we have a couple of hundred dentists out per day doing these procedures without using local anesthetic and not hurting the child. So I'll try to explain to you how that's possible and how that works. I showed you the electric handpiece. Using that and at 100,000 RPMs and just using mesial distal buccal lingual movements and no apical pressure allows you to do approximately 80% of your fillings without using local anesthetic and without hurting a child. It's very important that you wear loops. Without loops and good lighting, that's not possible because you have to really be able to see the tooth very well in order to have a light touch to go mesial distal buccal lingual with no apical pressure. You're basically painting your way into the tooth. So my burr of choice when I'm doing that is a 0508 pear-shaped 330 carbide pear-shaped type of diamond. It has a very small head. It's less than, the head is approximately 2 millimeters in length. And 2 millimeters is a good guide for how much you need in clean wall and clean gingival floor in order to successfully bond in a filling. The other burr that I use routinely when I do use anesthetic is a 557 crosscut Fissure carbide burr. When I'm finishing my composite, and that's for cavity preparation. Those are basically the two burrs that I use for cavity preparation. I don't use the 557 unless I use the 557 if I'm giving local anesthesia. For finishing composites, I use an egg-shaped diamond. Inapproximately, to get out the flash, I use a pointed white stone, and sometimes I'll use a 12-fluted flame-shaped carbide finishing burr. The other burr that I use for operative purposes, if I do a pulpotomy, I'll use a number 6 round a carbide burr. I'll explain to you how I do pulpotomies a little bit later in the video. And this next burr is a straight, sort of narrow diamond with approximately a chamfer, pointy chamfer end. And those are the burrs that I use. For doing the composites, I always etch for every filling that I do. We use a bonding agent that can be used with or without etch. At one point in my career, I started using an all-inclusive etch, prime, and bond, and 6 months later, I noticed that there was marginal leakage on my fillings. So ever since, I've used etch for all my fillings, selective etch if possible. Not all that careful about it being selective or not selective, but I etch for 20 seconds to get a good bond from my composite to the enamel. Most of my fillings, I'm using highly filled flowable composite. The brand that I like for the last couple of years is Kerr's Revolution. I find that it doesn't have bubbles. It has a lot of filler in it. It flows well. And when I place my flowable composite, I don't use the amber filter on my light because I feel that by having my loop light shining on my prep as I'm filling it with the flowable composite, it helps the composite set as I place it so that the composite doesn't run distal, that the composite stays in place. So I find that to be very useful. When I use our compactable composite, which this composite is GC America's Gradia X. I like Gradia X because it doesn't stick to the composite instrument. It's kind of creamy, and if you use your amber light, it gives you good working time to sculpt it. So anyway, with the compactable composite, I use my amber filter so the composite doesn't set up too quickly. The percentage-wise, I would say a good 80% of my fillings I'm doing with the flowable composite, perhaps 20% or less with the compactable composite. I find that the flowable is very adequate for our needs of doing in-school dentistry. Deciduous teeth are all exfoliated by the time the child's 12, so I don't need the composite to last for 20 years or anything like that. And I'm very happy with the results for that Kerr Revolution flowable composite gives. For a base, if I feel that my prep is deep, I'll either use Limelight, which is resin-modified calcium hydroxide, or I'll use Ionoseal, which is a resin-modified resin-modified glass ionomer. I use them more or less interchangeably. If I have a deep proximal box, I'll usually put 1 millimeter or 2 in the bottom of the proximal box with the resin-modified glass ionomer, because it'll absorb and release fluoride. When we do pulpotomies, which are not that often, instead of using formal cresol, which is pretty smelly, and it would smell up the classroom, and that would annoy the teacher whose classroom we're set up in, we're using ferric sulfate. It perhaps doesn't give quite the great result that people get out of formal cresol, but formal cresol is smelly, and also it's been proven to be carcinogenic in laboratory animals. So there's been a tendency to go away from ferric sulfate. As a base material, after the pulpotomy, either calcium hydroxide, we have calcium hydroxide, which is multi-cal, or I have some teams supplied with MTA. MTA is not that easy to work with, but it's certainly a very good material. And when we can expand our budget for supplies, I'll equip more teams with either powder and liquid MTA or MTA putty. That all being said, those are the tools that I use. I want to go over the theory behind how I prep the teeth and why I'm prepping them the way that I do. One of the important principles in doing fillings without anesthetic, and in your decision making on whether to do a pulpotomy or not do a pulpotomy, is incomplete caries removal. To dentists who have been to dental school or graduated from dental school, let's say in the last 10 years, you're probably very familiar with incomplete caries removal. Dentists who are in the generation that I was in of dental schools, or went to dental schools in the 80s or 90s, are probably not that familiar with, or may not be that familiar with, incomplete caries removal. When I was in dental school, we had to excavate caries so that there was absolutely no caries left. And that included infected caries or affected caries. Infected caries are basically the soft stuff, the soft, mushy stuff. Affected caries are the hard stained dentin. But when I was in dental school, there was no choice in leaving hard stained dentin. It was all caries had to be removed. And a number of times that would result in a pulp exposure, and that would lead to a root canal. But in those days, we were absolutely convinced that any decay left on a pulpal floor would expand after the filling was placed and eventually cause a toothache because the decay expanded. The major study that proved that wrong, the seminal study, was done between 1988 and 1998 at the University of Georgia. and that was the Mertz Fairhear study. And what the Mertz Fairhear study did was to drill into cavitated lesions, not excavate the caries, and simply bond composite over the non-excavated caries, but to get a good enamel seal. So they would etch, prime, and bond, seal the enamel with composite. They did approximately 150 teeth like that. They didn't fill them all with composite. Some they used regular amalgam, some they used bonded amalgam. But after the 10-year study, what they discovered was that the caries that were sealed in didn't expand. So that led to a statement that decay bacteria deprived of a source of nutrition is going to go dormant or die. And that was the start of incomplete caries removal. If you haven't read the Mertz Fairhear study, it's easy to find. You just Google Mertz Fairhurst, M-E-R-T-Z, F-A-I-R-H-U-R-S-T, 2 words. And if you Google Mertz Fairhear study, it'll pop right up on the first Google pick. There is another video that's really worthwhile to watch, and that's put out by James Bader. It's a YouTube video. James Bader teaches at the University of North Carolina Dental School, and the purpose of his video was to go over incomplete caries removal, but also to go over evidence-based dentistry and the scientific process to determine how a group of studies, when they're put together, become evidence-based, which is pretty much something you can count on as being true. So in order to find his video, it's the only video that he has on YouTube. You go onto YouTube and type in James Bader DDS. So those are the 2 videos that I recommend for getting a background and in incomplete caries removal. For me, I think I explained how I just tell a child that, okay, I'm going to go chase sugar bugs and fix your teeth. If you feel anything, it should feel a little bit like cold water. If you feel anything more than that, raise your hand. That means raise your left hand. That means stop to me. Sometimes I rehearse it. Unfortunately, I've been told that there are some dentists in the company who, in order to get out of, let's say, doing fillings that the child needs, and maybe they're uncomfortable in doing fillings, they'll say something like to the child, is it okay if I drill on your teeth? Or is it okay if I extract one of your teeth? That's just plain wrong. And in order to have a child be cooperative with you, you want the child to trust you. You want the child to feel that you have their best interest in mind and that they can trust you to do the dentistry. Now, as far as doing the fillings without anesthetic, what I find it's pretty easy on most children, not all, but on most, like I said, to do a mesial distal painting of the 0.5, 0.8, small. It's a little bit smaller than it's a pear-shaped diamond that's a little bit smaller than the 330 Carbide diamond that's traditionally used by pediatric dentists. And to paint your way into the grooves and pits and fissures of teeth that you want to fill, and to create 2 millimeters of clean vertical and gingival wall. With the 2 millimeters of clean vertical and gingival wall, you can get a good bonding seal, as Mertz Fairhear did, and go 10 years without the filling leaking and the decay expanding. Now, how much decay can you leave that's beyond your 2 millimeter gingival, your 2 millimeter of clean vertical wall or clean gingival floor? Basically, what I do is use a spoon excavator and take out all the infected dentin, the easily excavated, soft, infected dentin. And I leave the hard, demineralized, affected dentin, a carious affected dentin. So when it comes down to your prep is essentially taking away undermined enamel, unsupported enamel, creating 2 millimeters of clean vertical wall, and excavating the remaining infected caries, and then stopping. So I hope that the technique sounds reasonable to you, and I do that routinely for caries that I find in the pits, grooves, and fissures of teeth, as well as in proximal caries. I'm going to back up a little bit and talk about demineralization, remineralization, and my diagnoses for decay on the population that we treat. It's a little bit unreasonable to think that we can treat a Medicaid population and change their dietary habits and their brushing techniques so that we can apply multiple frequent doses of topical fluoride to remineralize decayed teeth. It's just not practical. So the way that I decide whether a tooth needs to be restored or whether I can watch it is if I have carious stain in the pits, grooves, and fissures, I'm going to restore the tooth. If I have qualified teeth for sealants and I have clean surfaces without carious stain in the grooves, pits, or fissures, or extremely minimal stain, I'll put a sealant on. When I'm looking at an X-ray, if I have E1 lesion, meaning that the decay has not progressed beyond 50% of the thickness of the enamel, I'll just watch it. If I have a lesion that has progressed beyond, looking at an X-ray and approximately beyond 50% of the thickness of the enamel, I'll diagnose it for a filling. We do have more choices for arresting decay, stopping the decay today than we did 4 or 5 years ago. And that is the advent of silver diamond fluoride. So let's say you have a child who is uncooperative. And like I said, we don't force the issue with a child. We don't use any verbal commands to behave. We simply send the child back to their classroom. We have another tool in the toolbox, and that's silver diamond fluoride. We've been using silver diamond fluoride for about 4 years in the company. Most states are paying for it. Some states pay more than others. And it's a treatment option for using for children instead of it's a treatment option usually for children who are uncooperative to receive fillings. In the United States, in general, or almost all the Medicaid plans I know of, or let's put it this way, I don't know of a Medicaid plan that perceives of silver diamond fluoride as the final treatment for a tooth. They perceive silver diamond fluoride as an interim treatment, something to delay the advancement of the decay so that the child could either develop emotionally to be in a better framework of mind for you to do the filling, or if you're going to come back and fill the tooth at a later visit, which is maybe in 3 or 4 weeks, it allows the arresting of the decay. Now, silver diamond fluoride is not 100% effective. Studies have been showing that it is approximately 80% effective. So it's not going to stop the decay in all the teeth that you treat. From my perspective, the greater motivation or the greater success that you have in getting a child to keep plaque off of their teeth affects the ability of silver diamond fluoride to be effective. So if a child is not going to brush their teeth and you apply silver diamond fluoride, it may be partially effective, but it probably is not going to overcome all the acid that's produced by the plaque. In any type of remineralization, you need to remove the acidity, lessen the acidity of the saliva in order to get the calcium phosphorus to go back into the tooth to remineralize it. So I think your chances of success with silver diamond fluoride increase as you're able to motivate the child to keep the plaque off of their teeth. It's a tool in our toolbox. However, if I have a child and I've diagnosed the child for fillings, and I've spent the time developing a rapport with the child, I usually try to get all the fillings done in one visit, if I can do them in a half hour. And if I'm not using local anesthetic, I use the pear-shaped diamond, this very small pear-shaped diamond. Now, you may be wondering whether deep decay is a candidate for incomplete caries removal. And I can tell you definitively that it is. It may be counterintuitive, but the deep decay, when you're doing your outline prep, the deep decay insulates the tooth from feeling the coldness of the water that's spraying out of your handpiece. And so what I will do is I'll use the pear-shaped diamond, I'll make the outline of my preparation, and then I'll spoon excavate the remaining decay. And then I'll either fill the tooth or I'll put a base on before I apply my edge. So there's a certain technique that I use in order to do interproximal class 2 cavities that I'm doing without local anesthetic. And what I do is I go along the marginal ridge and go buccolingual on the marginal ridge until I've created my proximal box. Once I've created my proximal box, then I go inwards along the central groove, and I try to keep my depth at approximately 2 millimeters. 2 millimeters is the length of the pear-shaped diamond. And after I've gone through the central groove, then I'll come back and try to create an S-curve so I don't have a sharp angle from my central groove to my proximal box. And I'll be able to have a bulk of composite. Now, that is in general for how I prep a class 2. So to review that, I do my proximal box by coming down the marginal ridge and just going buccal lingual along the marginal ridge. And then I'll do the central groove, and then I'll create an S-shape curve from the central groove to the buccal and the lingual of the proximal box. I'll then take a spoon excavator, excavate out the infected dentin, and then if I feel that I'm very deep, I could put a base on of limelight or ionoseal, which is our resin modified glass ionomer. I'll put a Toffelmeyer band on, and I find that I can use a Toffelmeyer with a pitot band and use my mirror to make the band kind of circlish, and then place it and tighten it without hurting the child. If I have a closed gingival floor and I'm using flowable composite, I find it's really not necessary for me to put a wedge in. If I need to lightly wedge in order to close the gingival margin, it's really not a big deal. I then etch for 20 seconds, and like I said, if I'm deep and I'm concerned that my etch might irritate the pulp, I'll do a limelight or a ionoseal base. After I've etched, I'll flush it out, dry, and when I'm placing my flowable composite in my proximal box, I'll put a millimeter of material in, millimeter of flowable composite in first, and then set it, cure it. And the reason why I do that is because if I try to do anything thicker than that, I find that the composite shrinkage shrinks up from my gingival floor. So that basically tacks it down. Sometimes I'll use the ionoseal as my 1 millimeter of composite material on my gingival floor. I'll then layer and bond in my flowable composite. One step that I just remembered that I forgot is after I've etched and dried, I used bonding agent. I scrub that in. I then I don't have to worry about leaving it for too long because I've already etched the enamel. I then blow dry it with air, have it pretty dry but not absolutely dry. Well, I blow dry it with air to both blow off the solvent of the bonding agent and to thin it, and I cure the bonding agent, then place the composite as I told you. And that's pretty much the technique that I use for when I don't use anesthetic. I don't drill using a 557 cross-cut fissure. I use the pear-shaped diamond. I'm only searching for getting rid of the unsupported enamel and infected dentin, and having a 2 millimeters of clean vertical wall. And in deciduous teeth, you only get about a millimeter thickness of enamel. So part of the wall is usually, some of the vertical wall is dentin. In adult teeth, sometimes I can get 2 millimeters, 2 millimeter thickness of enamel, but usually part of the prep is touching dentin. When I use my compactable composite, it's usually for a larger preparation, and like I said, I use a composite instrument, and I use my amber filter in order to make it so that I have more working time to sculpt the composite. I'm trying to keep the length of this video at a reasonable length, so I'm going to pass on from fillings to when you might want to do a pulpotomy. In the past, pulpotomies were usually done for deep decay that was approaching the pulp, and today that criteria has changed. Pulpotomies are not necessary on teeth that have deep decay but are asymptomatic. So if you have a tooth that's let's say you have a deciduous molar where the caries are approaching the pulp, you'll want to test and see whether that tooth has significant caries that have already caused a symptomatic tooth that perhaps is irreversible pulpitis, or you'll evaluate the tooth and realize that you can use incomplete caries removal in order to treat that tooth without a pulpotomy. In talking about pulpotomies, I want to go back to X-rays and what I'm looking for, or what kind of X-rays I'd like to be taken. If the bite wings or the anterior X-rays show deep decay, then I'm either going to need a periapical X-ray so that I know that there isn't an apical lesion on the tooth, or for deciduous molars, I'll need to at least see the furcation. In deciduous molars, because of the size of our sensors, it's often difficult to get a periapical X-ray of them. But I could tell from the interproximal whether that tooth is, I can usually tell from the interproximal furcation whether that tooth is vital or non-vital. If there is a radiolucency in the furcation, then the tooth is non-vital. Also, for deep decay, I test the teeth, but with percussion. If the child reports to me that the tooth does not wake them during the night, or if they feel the tooth that it's a very brief sensation that goes away quickly, and I can percuss the tooth and it's not sensitive to percussion, then I will assume the tooth is vital, and I will treat the decay with incomplete caries removal. The James Bader video that I recommended to you by going on to YouTube and just typing in James Bader DDS, he covers that subject of deep decay, asymptomatic deep decay, and how the tooth doesn't really need a pulpotomy. And there's a video which, if you want to find it, you go on Google and just put in UCLA pulpotomy video. And that video, we'll pull up a video that was done by Chanel McCready, who was at the time the assistant chair of pedo at UCLA. And she does a very nice job in explaining how to percuss teeth and on a child and determine that the tooth is vital. And she also very nicely goes over how to do a pulpotomy. And the video is very well done. So for those of you who have not done very many vital pulpotomies, I suggest that you go onto Google in UCLA pulpotomy video, and watch Dr. McCready's video on pulpotomies. So going back to the x-rays, for all deep decay, I like to see either a periapical x-ray or at least the furcation area of deciduous molars to evaluate for vitality. The other thing that is of interest with bite wings and the size of the sensor that we have is that sometimes for kindergarteners or preschool kids, it's virtually impossible for them to bite down enough without being hurt, to get a bite wing. And in those cases, I recommend that the X-ray technician take something that's called a horizontal PA. And that simply means holding the sensor in a horizontal position, getting an X-ray which will show the deciduous molars of the upper right, upper left, lower left, in lieu of taking bite wings. And that's very effective. So I don't mind X-ray technicians saying, oh, child's uncooperative for X-rays, which sometimes that occurs, but if they can't get bite wings, I appreciate everyone at least attempting to take a horizontal, what I call a horizontal PA of each quadrant. So getting back to the pulpotomy. So when would you do a pulpotomy? Naturally, if the tooth's necrotic, you can't do a pulpotomy. You would have to do a pulpectomy. We don't carry files in our equipment, and we simply don't do pulpectomies. But we do vital pulpotomies. And in that case, you would have to determine that the tooth is vital and that you can achieve hemostasis and remove the coronal pulp and do the pulpotomy. A thing that's interesting with the Dr. McCready video is she talks about iatrogenic pulpotomies, meaning that when you're removing the decay, that you've exposed the pulp. Now, incomplete caries removal makes it doubtful that if you pay attention and just remove, if you have a vital deciduous molar and you just remove the infected dentin and leave the rest, you're very unlikely to expose the pulp. But Dr. McCready did that video in 2014 or 2015. And at the time, incomplete caries removal as a valid technique, that is, not removing all of the decay, but leaving the affected dentin, wasn't fully recognized. And exposing the pulp, trying to remove all of the affected dentin was quite a common experience, both in pediatric teeth and adult teeth. So the incomplete caries removal is a technique that we've embraced in the program, and if you're unfamiliar with it, I I recommend that you become familiar with it and embrace it because it is evidence-based. If we do a pulpotomy and the child reports that the tooth sometimes hurts and the pain is lingering but goes away, and you've determined that the pulp is probably vital, then of course you're going to have to achieve local anesthesia, and remove the coronal pulp, obtain hemostasis, and then fill the tooth. To make it easier on you, what I recommend is that once you've attained anesthesia, that you reduce the occlusion of the tooth. When in saving the tooth with the pulpotomy, it doesn't matter if the tooth's in occlusion. You basically want a space maintainer so that when the permanent bicuspids come in, they're not crowded, you've maintained space for them. So removing the occlusion won't adversely affect your final result, and it'll make it easier for you to find the pulp and remove the pulp. Another thing that's important to remember, that the distance from the roof of the pulp chamber in a pediatric deciduous molar to the floor of the pulp chamber is sometimes very narrow. So you don't want to press downward with the burr that you're using to remove the pulp. You want to kind of press down and then pull up while the burr is rotating, because you could easily perforate the pulpal floor. So the technique to find the roof of the pulp chamber in upper deciduous molars is a triangular prep, and in lower deciduous molars it would be a rectangular prep. And once you find a pulp horn, then you want to connect them. And I use a number 6 round burr to remove the roof of the pulp chamber and connect the pulp horns. In deciduous lower molars, you usually have 4 pulp horns. In deciduous upper molars, you usually have 3. After I remove the roof of the pulp chamber, I will press my burr down to the bottom of the press my burr down to the pulpal floor and pull up and remove ledges of the roof that are on the roof of the pulp chamber. Try to use my number 6 round burr to remove most of the pulp. I'll then go to a spoon excavator, and after the spoon excavator, I usually put in a cotton pledget and wait for 20 or 30 seconds before I remove it to see how good a hemostasis that I have. If I was very lucky and obtained hemostasis just from that, usually what I'll do is flush with chlorhexidine. And that's an important step, because when you're using ferric sulfate, even though we use distilled water and we use water treatment tablets, you want to be certain that you kill certain bacteria that can actually eat the iron in the ferric sulfate. So using the chlorhexidine is important. We don't use, we're not using formicresol, we're not using sodium hypochlorite, but the chlorhexidine should help you out with that. You can use a chlorhexidine pellet. To be sure that you've arrested all hemorrhage, we use ferric sulfate. It's called Stat Gel. It's brown in color. The tip that you use kind of has a little felt tip on the end. What I usually do is apply it to a cotton pellet or let's say I flush out the tooth. If I have just seepage, I'll apply the ferric sulfate to a cotton pellet, apply that in the tooth, leave it for approximately a minute, remove that, hope that the bleeding has arrested. If the bleeding hasn't arrested, sometimes I'll use a number 2 round burr to go into the orifices of the canals to try to remove any hyperemic pulp tissue, and then go back to the ferric sulfate again. Sometimes what I'll do is I'll leave the ferric sulfate pellet in and see another patient and then remove it. That's at last resort. I'd prefer not to leave the ferric sulfate in for that a length of time. But if you do that, you can be pretty sure that if it takes you 15 minutes to see a patient and bring back that patient that you're letting sit, that bleeding will be arrested. And you can go on to use a spoon excavator to clean up the ferric sulfate and either place a layer of calcium hydroxide or a multi-cal or the MTA, and either the powder liquid MTA or the MTA putty, and then float a layer of either ionoseal or limelight over that, light cure that, and then do a buildup. As far as doing stainless steel crowns, we as general dentists are really not that great at doing stainless steel crowns, but what we found as a company over the years is as my 14 years in the company has gone by, the parents are less accepting of stainless steel crowns. In the privates, in dental offices, zirconium crowns that are tooth colored are becoming very popular. Preformed zirconium crowns. Stainless steel crowns are becoming less popular. And even though we have permission to, or consent to do stainless steel crowns, we won't, our guidelines in the company do not do a stainless steel crown unless you've talked to the parent and gone over the risk, benefits, and alternatives. If you can convince the parent that the tooth will be stronger with the stainless steel crown, although it will not look aesthetic, and that the alternative would be to do a composite buildup, that would be more aesthetic but would have a greater possibility of fracturing. In our experience, we've been doing a lot of composite buildups, and the literature is showing that composite buildups and large composites are pretty stable to the tune of 80%. And it is, in my opinion, it's the way that I handle my large fillings and pulpotomies instead of doing a stainless steel crown. But if you do want to do the stainless steel crown, make sure that you've discussed the matter with the parent before you place the crown. Years back, even though we had consent, if the parent wasn't talked to before we placed the stainless steel crown, we got calls to the company for the parent complaining that it made them feel like a bad parent because someone looking at their child smile, and even if there was a deciduous molar, would be unhappy and think that the parent wasn't taking proper care of their child's tooth. Anyway, it's an evolving process. I don't want to belabor the point, but that's how I approach doing a pulpotomy on a child. If a tooth needs an extraction, we also want to give the parents a heads up, try to call the parent and tell the parent that one of the baby teeth need to be extracted. We only extract deciduous teeth, and tell the parent the reason. It's usually because of infection, pain, or interference with the eruption of a permanent tooth. But even if you can't reach the parent and you decide that because we have permission and it's in the child's best interest to extract that tooth at the visit, please go ahead and do so. But make sure that you've left a message for the parent, and also try to get your dental assistant to try at a later time to contact the parent about the extraction. Of course, we have forms that we send home with post-operative instructions. If you do an extraction, we don't want you to send the child back to their classroom until you've obtained hemostasis, until the socket isn't bleeding. Now, before I wrap this up, I want to go over a pretty important concept, and that is, when a parent signs up for our program, what are their expectations? Well, we're telling the parent that we provide comprehensive in-school dental care. And we're also telling the parent that we provide the care that most general dentistry offices would provide if they took their child there. We don't provide specialty care such as palatal expansion, fixed space maintainers. We do have a trombone type fixed space maintainer kit that you're welcome to use, but we don't do tongue cribs. We don't do dentistry that is generally provided by an orthodontist or a pediatric dentistry specialist. Now, once we've done that, if you, as one of our practitioners, needlessly refer the child out for fillings that can be routinely done in a dental office, you tend to upset the parent and the dental office that you send the child to. Now, as a portable program, on the back of all of our take-home forms, we have a list of all the dentists in the area of the schools that we're in who have agreed to take referrals from our program. And any of the parent that receives a take-home form from us will see the list of the schools. If they're dissatisfied with their program, they're certainly welcome to look at that list. I might have said schools, a list of general dentistry offices and pediatric dentistry offices in the areas of the school where we provide care who are willing to take our referrals. The parents are certainly welcome to take their children to those offices, but the parent tends to get upset if we see the child and we don't provide the general dentistry services that a general dentistry office would provide. The point of view from the parent is, I wouldn't have signed up with you if I knew that you were just going to clean my child's teeth, put sealants on, give my child a fluoride treatment, and send my child to another dentist. That I should have just taken my child to that dentist in the first place. So please, if it's within the scope of general dentistry, please provide the care in our in-school program. For myself, I pointed out that I like to if I can, do all of the treatment that the child needs in one visit, considering the time that I've spent developing a good rapport with the child. I do that. I also do that in order to prevent unnecessarily having to go through the expense of seeing the child a second and a third time for return to finish appointments. Also, the child will not necessarily get me for the return to finish appointment. They'll get another dentist, and that dentist in order to do the restorative service, to provide the restorative care, we'll have to develop a rapport with the child. So I think you know my point of view and how I look at it. If you're uncomfortable with performing the procedures, call me or call our clinical department, and we'll make arrangements for mentoring so that you do feel comfortable. We're certainly available to you. I think I've covered pretty much everything that I want to in the video. If you have any questions, feel free to reach out to me or any other members of the clinical department. When dentists come into our company, we send out a lot of onboarding information which contains our contact information. All of you who are in the field, your dental team managers have our contact information. The other thing I want to point out to you is that I certainly enjoy doing what I'm doing. Working on most of the children we work on are from 5 to 12 years old. They like to have fun. They have a very good outlook on life. I find them to be enjoyable to be around. It makes me feel younger. And I hope you, if you're just starting with us, that you achieve as much enjoyment from seeing children in school and treating their dental problems and trying to motivate them to keep their hygiene at the highest level and maybe to eat less candy than they usually do. I hope you enjoy it as much as I do. And I look forward to you contacting me with any questions you have and interacting with you in the future. Thank you very much.